Okay, Beck.
All right. Hi, everybody. Welcome. Welcome to some familiar faces and new faces. We are thrilled you're here with us today. I'm Rebecca Berman, Glenn's sister. I'm proud to be moderating today's program. For those who've been with us on a weekly basis, having Glenn help us lead the way and take us through the news, we're going to be doing something slightly different today. So the first bit is going to be, Glenn is going to be walking us through answers to questions that he has received during the week. And we are going, in the second bit is we're going to ask you, if you have a question, you can send it to me in the chat, and I'm going to work to moderate and call on you to ask your question. So are we game? Everyone feeling good about this? All right, let's go. So I wanted to introduce you to our host, Glenn Grossman. He is an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and at UNC. He has been involved in epidemiology projects with Medicare, Medicaid, Veterans Health Administration, Military Health Service, the CDC, and other programs in the US and outside of the US. He is currently Senior Director of Outcomes Research and Epidemiology at Novartis, but all views expressed today are his own. So with that, Glenn, maybe we should begin with you kind of give us a weekly update on what's kind of happening locally and around the country. So maybe we'll kick it off with that.
Sounds great, Becky. You know, I was trying to see if we could do a poll, and I don't know if I can. Oh yeah, here's polling. All right, so here's a quick poll. Okay, without Googling the answer, roughly how many new cases of COVID-19 were diagnosed in the US in the last week, according to the US CDC, so June 21st to June 27th. Here, I'm launching it now. So you can put what you think is an answer. So was it 100,000 new cases, 150,000 new cases just in the last week alone, 200,000 or over 250,000? All right, I'm gonna go ahead and end it. All right, so here are the results. I don't know if you can see it, but basically it was evenly split between 150,000, 200,000, and greater than 250,000. And in fact, we had over 250,000 new cases diagnosed just in the last week alone. All right, I'm going to stop sharing this and I'll share with you my screen. Right, we are sharing this. All right, so let's come back. Here we are. Yes, so what we're looking at is, as you know, the curve that we've been seeing every week, and you see that over the last week we've jumped up. There were over 255,000 new cases just in the last week alone. There is regional variation, dramatic regional variation, and when you look region by region, you see that the Northeast was going down. Now we've kind of gotten so that we have the same number of infections on a week-by-week basis. So we're not going up or going down anymore. Pardon me. In the South, it's going up dramatically. In the West, also it's going up, although not quite as much as the South. And Midwest, which had been going down, is now slightly going up again. Um, yeah, I mean, I can show you where the hotspots are just at a high level. So right now you see so there's two ways of looking at this. One is where is the massive volume of new patients? So where are the greater numbers? And then the other way of looking at it is where are they increasing the most? So right now, this is where the hotspots are in terms of where the greatest numbers of people are. Right now, we see Florida leading the way, almost 10,000 new positive cases per day. Texas over 5,000, California over 5,000, but Arizona has a lot. It's coming up from behind. So this is where the total volume is, but the rates of these countries vary dramatically. So California, you see that the uptake it's getting a little bit steeper. Similarly, when we look at daily positives, this is Texas we're looking at. This is also somewhat steep. Arizona is definitely much steeper than those other states. So even though the total number is lower, it will not be lower for long. Florida is also starting to go dramatically up. Florida, funny thing happened in the last week or two with Florida. Not so funny. Because they didn't like the results that they were getting and they didn't like people to see what the hospitalization rate is, they've now changed the reporting. So we can no longer trust hospitalization data that comes out of Florida. I could tell you if I don't know what I did with the graphic. But basically now we just can't depend. Here it is. So basically the Surgeon General in Florida didn't like that the intensive care unit beds were approaching where the capacity was. We're not too far off. And so now Florida only wants hospitals to report patients that are described as intensive levels of care. So maybe they're in the intensive care unit, but if they're not actively getting intensive levels of care, whatever that means, there's no definition, then they can interpret that and just send in whatever they want. So it doesn't help us. Ultimately, we need the number of beds to be free for people. But so this is we can't interpret that number and we can't include it in any of our reporting. Yeah, so here's Florida, Nevada starting to creep up. You see this line right here. It's something that's going to be hitting us soon. And then finally, Georgia is another example where the numbers are starting to go up. All right, this is it for now. So let's go through. We can try to get to a bunch of questions. What's on your list?
Okay, so next up, this past week, the CDC said that there were 16 to 20 million people who have been infected with SARS-CoV-2 during this epidemic. Are they mostly mild cases? Because only 2.5 million have been diagnosed. Can you break that down for us, please?
Yeah, so there's a couple things to this. So first, there's this graph, and this graph is what we were just looking at, the number of new diagnosed cases per day. And we see that the number is a lot higher even. We've exceeded the peak that we had even back in early April. But the key thing that you need to always remember is that it was really hard to find a test back in March and April. So the majority of people who are getting infected, even people with symptoms, so the majority of people with symptoms getting infected were not getting tests back in March and April. And so then this is not the real shape of the curve in terms of the infections. These are only the diagnosed cases, not even the symptomatic ones. These are just the ones diagnosed and reported to the CDC. And so when you look at the estimated total number, there's still some uncertainty, quite a lot of uncertainty, but you see that the shape is quite a lot different. And so you see here's March and April, here's where we are now, June 28th, and you see that the total number is quite a lot lower than the total was back in late March, early April. And these numbers too, you'll see here how it peaked in terms of the cases was not until early April, towards mid-April when we were seeing this peak. And that was because of when testing was occurring. This is when the assumed infections occurred. And then the people were typically didn't get symptoms for maybe 5 days or a week after. And so maybe didn't get tested for a week after that they were exposed. And so there was sort of, this infections happened earlier. So what this means is a couple of things. First, you can see the slope of this curve was far higher. So we didn't really know before the lockdowns. And so people were getting infected at a much faster rate. Second, what this means is that Right now, even though the rates are getting higher in some of the parts of the country that we're looking at, the absolute rate is still lower than it was back in March and April. And so or let's say this is March, April isn't until here. So that's a big thing. The other takeaway that we can get is that there have been approximately 2.5 million reported cases. So that's here, the area under the curve here, 2.5 million cases, approximately 125,000 reported deaths for COVID-19, which we know is an underestimate, the same way that we know that this is an underestimate for the number of cases. But if you just divide that, the total number of deaths divided by the total number of reported cases, then that means that the case fatality rate is around 5%. So just the 125,000 over the 2.5 million. So it's roughly 5%. If the number of infections are maybe 10 times as much as the reported cases, then that would mean that the infection fatality rate, not just the reported cases, but the total infections would come down by a factor of 10. So instead of it being 5%, then our best estimate is that it's 0.5%. And we do understand that this varies dramatically based on age and comorbidities and other things that make some patients at higher risk. The biggest one, of course, being age by far. And so yeah, I think that answers that question. Well, so here's one other thing that's interesting about this range. So my best estimate right now is that, let me go to this website. All right, whoops. I need to pause share. All right, I'm getting the knack of Zoom. All right, so, whoops, let me try this again. Pause share. Oh wait, new share. And one more time, resume share. Okay. So let's see. So we are looking here at a few things. Okay, projections. This is what I want to show you. So for the United States as a whole, this is what we're looking at for newly infected. In terms of total infected, this puts us at between where we are now. My best estimate is consistent with what we're seeing here. I'm estimating that we're probably between around 5% of the population infected and 6.6 or 7% of the population infected currently. My best guess is it's closer between like 5 and 6, maybe 5.5 now. What does this mean? So if we talk about herd immunity, which we still don't know what that level is, we are nowhere near anyone's best guess. So, but even if it's 50%, 70%, whatever it is, we're still at least an order of magnitude away from where that is. So we still have a long way to go with this thing, even if there is protective immunity that causes herd immunity, which we don't know yet. But then the other thing to look at here is, so this is going into July, August, September. So here, the question is, where are we going to be at the end of the summer? And this all depends on the choices that we make over the next week or two with lockdowns. And so if we don't lock down, then we are very likely, based on the shape of some of those curves, heading towards a 12% infection rate by the end of the summer. If we do lock down, then it'll be closer to 8.5% or so. And so this is the choice. We're about to make some choices. In terms of, do you want me to talk about whether I think we'll lock down or not? I know that was coming a little later. You want me to jump on that?
I think that's a good idea. That's definitely a question that's on a lot of people's minds.
Okay, so let me jump ahead. So the biggest thing is not necessarily the cases. There's two things we need to be paying attention to in terms of whether we're going to lock down. Three things, I would say. Two important things, but the third one decides it. The first important thing is the number of hospitalizations. Because if there's cases, but if they don't require hospitalization, then it means that the symptoms are mostly just things like a cold symptom, or it's not as severe an issue if people aren't going to the hospital. and they're not dying. So the first thing is the hospitalization rate. The second thing is the death rate. So if the death rate, if people do go to the hospital, whatever rate they do, even if they're not going very much, if the death rate starts climbing again, then that's another reason to lock down soon. And then the third thing that will decide whether we lock down or not, outside of the metrics, which should be the deciding factor, is the polling, the politics of it, the optics. And so let me talk about a couple of things. First, the optics. And this is unfortunate, but this is just the way it is in this country right now. So when you ask, is social distancing worth the cost? Democrats, over 85% of us, or people who are Democrats, let's say, are saying that social distancing is worth the cost. Whereas Republicans, or those among us who are Republicans, generally it's closer to 50% say that social distancing is worth the cost. There's a wide divide in a lot of areas between Democrats and Republicans, but what this means is that in areas that are largely Republican, there is a lot of animosity to shutting down. It's going to be extremely hard to shut down in many of these areas. And what that means is that because of that, it's when the lockdown happens, and it will happen, when the lockdown happens, it will probably be too late because the decisions will be made based on pain that can't be avoided, that everyone perceives in the public. It's on the news. And so the Republican people who are voting for the leaders will have to change their numbers. Instead of 50% saying social distancing is worth it, those numbers are going to have to come back up, because only then will it be politically plausible for the lockdown to happen. And that's probably not going to happen until we start seeing hospitals overflowing and this kind of thing. The problem is, we know that once we see that signal, it's going to be weeks until we actually reach the peak past that, and then weeks more until we go down to a level that's below that. And so what this means is, I fully believe that before the end of the summer, probably much sooner, we're going to see multiple states locking down, and the optics are going to be different than the optics that we saw earlier on in March and April, when New York City, New Jersey, the Northeast was hit the hardest, and the rest of the country locked down. I think that the television is going to be, we're going to see things that we haven't seen in a while, and our eyes are going to be glued to that. And so this summer, that is going to be the story that we're going to be seeing. One thing that I saw here's just a couple just quick slides, just a little bit more on this. So New York issued stay-at-home orders to stay in place, to shelter in place on March 20th. At that point, there were approximately 35 reported deaths for COVID-19. Based on that lockdown and where we are now, we've reached over 25,000, or approximately 25,000 deaths in New York State alone. And this was the lockdown here. So that means that the lockdowns, the longer we delay, the higher this curve becomes. I'll get into the rates of death, the death rate in a little while, but first let me just show you some other curves just in terms of where we are on the uptake curve. All right, so one thing that I thought was interesting was to show the cumulative positive cases. So these are reported diagnosed cases, that this is the total amount. And so you see in the Northeast, the reason that doesn't come down is this is the cumulative amount, the total amount. And so you see that it was going up, and now it's mostly flattened, and it's increasing a little bit, but it's really it's flattening out dramatically. In contrast, the South is going way up, and the West is going up. And so I thought it would be an interesting exercise to compare the slopes to see where it compares where the Northeast was. And when you compare it, you could say, oh, look, it maybe hits a little bit here, but even at this point, there was an inflection point where it was starting to go down. So it's probably closer, it's a really good fit right there in terms of where the infection was, the rate was. And then similarly, the West, when you compare that, it looks like just on the angle, it looks like it's a pretty good fit right around there. And so what does this mean? So we locked down in the Northeast right around here, right around March 20th. And that March 20th lockdown generated this curve for us. And so we're looking at the South here and the West here that are not locked down, generating these curves. And so, so this is worrisome. The thing that is not causing concern for people, so this is the first thing, is that, so the shape of the curve, we're going to see a lot more infections and we're going to see a lot more hospitalization. So that first part, the hospitalization part, is the first indicator that we're going to need to look at. And I'll get to that in a second. But the second thing is the deaths. And surprisingly, for a lot of people, but not for me, is that although the number of cases is rising dramatically, the death rate is not rising dramatically. And so what is going on here? And so for me, the obvious thing is that, as an epidemiologist, is that, well, this goes back to the curve. This explains it. Early on in the epidemic, there were a lot more infections than those that were diagnosed. So typically, because there were not a lot of tests, the only people that got tested were the ones who were going to the hospital and who were the sickest of the sick, because the other ones were just told to stay at home, to don't go out. So they didn't even know. So that means in New York City, as an example, when you compare New York City diagnosed cases with hospitalization, which I'm going to just flip back and forth, you can see that there's a little bit of noise in the cases. But in terms of the uptake curve, it's pretty much the exact same uptake curve. And that's because what I'm talking about right here is that the tests were mostly conducted in the hospitals themselves. And so as a result, they overlapped. Whereas now, where testing is far more common, we're seeing a delay between testing and hospitalization, which is good because now there's a lot more testing. The problem is the death, well, not the problem. There was in New York City around a week lag between, maybe a week or two, between the hospitalizations and the deaths. So there was a far longer lag between the first infection than the diagnosis of the case with the test, then the hospitalization, although those two things typically happen very, very near in time, simply because of what I just said. There weren't a lot of tests available. And then finally, death. And so there was the overlap was really in terms of hospitalizations and cases. Now we're seeing those separating, and then deaths. Now, the major explanatory factor for that was age. And let me see if I have a good difference. Oh yeah, here, this just explains it. Early on, most people didn't know a lot in March of what was going on. So people who were 50 or 60 were still using the subway into New York City. We're still going out and about the same way that they were. We didn't really change our behavior in early March. And so or at least before the lockdowns, we did a little bit, but not a lot. And so as a result, this is the diagnosed cases. This is not the infections. But among the diagnosed, and again, this is probably largely hospitalized people because that's where the tests were, you see that the people over the age of 45 made up a much larger number than the people under 45. In contrast, now people under the age of 45 make up a far, far larger percentage of those who are being tested positive. And so the primary reason for this, there's probably two reasons. One, despite the lockdown opening up and people can go out, typically the ones who are older and the ones at higher risk because of the age or because of their comorbidities are not going out as much. They're personally still sheltering and are not going out as much. And so their infection rates are not, they're not being diagnosed as much, and so probably not being infected as much right now. Whereas the ones that were infected were the ones who identified as being at lower risk for infection, or if they did get infected, at lower risk for hospitalization or death. And they were right. The people under the age of 45 are at much lower risk for stuff. The major problem now is that all of these infected people are now part of the long chain of infection. And that one person who gets infected, who identifies as being at low risk, will now infect all of these people behind them. They're going home, they're infecting their households. So people in their households that decided that they were averse to the risk because they felt that maybe they were older or had other comorbidities, now they're being infected at home. And so there are people, maybe 1 or two behind the person who's infected, where when you look through the chain of infection, maybe this person will be hospitalized and die, and maybe this person will be hospitalized and die. And so what that means is that the lag that we're looking at is not a 1 or 2 week lag because the infected are about to die. The people who are infected are healthy generally. Obviously, there's still increases in hospitalizations that we're seeing in some. Here's Texas, Arizona. But overall, they tended to be a much healthier cohort of people. The problem is that it's the chain of infection. So the lag that we're seeing is not going to happen as sharply in the next week or two as we saw early on in New York City when it jumped between, primarily because of age, but also because of the other comorbidities. But what it means is that the infections here are now infecting other people through the chains of infection. And so rather than seeing a large increase in death in a week or two, probably in another month, after it's gone through 1 or 2 more people in terms of the higher risk people, we're going to start to see the deaths rise. Hospitalization is going to happen before that. And so that's the first metric. And that's what's going to really cause the optics, is when we start seeing hospitals overflow. And to that, let me share with you a great website I've seen on that. So this is the hospital ICU bed occupancy rate. And what we see here are that the darker places are approaching higher levels of occupancy. And once they hit 100%, there are no more beds. There are limited things they can do to increase the capacity a little bit. So for instance, maybe they can start putting people in hallways and stuff, but there's just not enough equipment in the ICUs and the hospitals at large. The ICUs are the really demanding spots though. And so in some places, maybe if there's overlap, they can start sending people to adjacent counties, but you can see that the South and parts of the West are really getting close to capacity, and that's very problematic. When you look at, let's see, the test and trace, I can go back to that. A lot of states are really not, they've almost given up on testing and tracing. And so that means that it's out of control. And because of that, the question is there a way for them to avoid lockdown? So for instance, what if they just take a step back? They don't lock down, but they just make face masks mandatory everywhere and make social distancing more mandatory or whatever. The problem is because it's out of control, they don't have any contact tracers or they have very few. Typically, we're looking at 5 to 15 contact tracers per positive test. Anyone who tests positive for coronavirus. And in Arizona, as an example, they have less than 1. They have approximately 0.1 tracers per positive test. And so these numbers are not good. It's out of control there. And so that means that we see what's happening, and there will be a lockdown, and it's not a matter of if, it's a matter of when. And so that's where we are. Let me just see if I have anything else to share here before I open it back up. So I talked about age. I talked about, yeah, I think that covers it. Unless, do you have any more specific questions about that?
Well, I have to say, Glenn, I'm glad that at least one of us paid attention in statistics class and beyond, because you certainly are breaking this down for us in a way that makes it manageable. So ready, let's talk. We're talking a lot of statistics. Now let's see how well you paid attention in biology, hopefully better than I did. And let's shift over to the biology part of this, meaning, can you tell us how this virus impacts the immune system? Folks want to know, do you have an easy way to understand the impact?
That is a great question. And I made a graphic. Hopefully it's going to break it down pretty easily. So we will see. Here it is. All right. So basically, I look at this as a call to arms versus a call for reinforcement. Normally in the cell, so these are the ways that a normal cell responds to an infection. So either there's a call to arms where it tells its neighboring cells to prepare for an attack. So there's a virus nearby, arm yourself. And so like you batten down the hatches, you close the windows, shut the doors, you get out the bats and ward off the virus. This is done by something called an interferon, or a set of interferons. And this tells all the neighboring cells to arm themselves up and prepare for battle. This occurs on the cellular level, and it's actually the adjacent cells themselves. This is all happening in the cell itself. But then there's the systemic stuff, the things happening around the body. And so the other thing that happens is the call for reinforcement. And this is where the cell that's been infected essentially calls 911 and puts something out into the blood. These things are called chemokines. And it's like a signal for 911. And the T cells and the B cells rush to where they see the signal, and that they home in, and then they just attack the cell. They don't even bother attacking the virus. Antibodies attack the virus. What these do when they hear the cell is under attack, they go and they eat the virus, or not the virus, they eat the cell that's been infected itself. And so this is another way that the immune system works, that's regardless of antibodies, it just goes, and these macrophages and these other things go and they eat the cells themselves that are infected and take them out of commission. And it's a way of just stopping the spread, because instead of just dealing with the virus itself, you just take out the whole cell and it makes it much easier. But SARS-CoV-2 is very smart. And so most of the time viruses impact interferons or chemokines or both. And because otherwise, if they didn't impact them, we wouldn't have a viral infection associated with that virus for very long, because the body would just have a call to arms and call to reinforcement and eliminate it. But so all viruses, including flu and measles and everything, impact both of these things in some way. But SARS-CoV-2 is unique. And so like many other viruses, it reduces interferons. So if the neighboring cells don't know that they need to arm themselves and need to batten down the hatches, and so their front doors are wide open, the neighboring cells. And so it makes it makes it very easy for SARS-CoV-2 to just gingerly go into the neighboring cells and go and infect those cells too, because it disarms them. But then what's interesting about SARS-CoV-2 is that it doesn't reduce the chemokines. It doesn't reduce the call for 911. Instead, it floods the body with a call for 911. It overwhelms the body. And so as a result, the body perceives that there's calls for 911 happening all over the body. And so the T cells and B cells that are stimulated to go and rush to the cell, they don't know where to go. And so it sounds like 911 is coming from over here, and 911 is coming from over here, and from over here, all at the same time. And so it's an interesting way that's disabled the immune system, not by reducing the amount of chemokines, but by flooding with too many, and so the body doesn't know how to respond. And this is part of what this is causing this storm in our bodies. And so you might read in the news about T cells or B cells being depleted. And so for some people, the white blood cell count is going down as a result of this. Normally, white blood cells go up to respond to infection. In this case, it's like HIV in some ways, where it's actively infecting, reducing the white blood cells themselves, rather, not infecting, but reducing the white blood cells themselves. As a result of this call for reinforcement, these chemokines just going crazy. And so this is happening in maybe as many as 30% of people who are infected, and it is largely among those who are the most seriously impacted and hospitalized. This is being seen quite often. So I can tell you more about it in future weeks, but there's the science behind it. I mean, I can go further into the details in terms of what's being involved. We talk about the cytokine storm and the chemokines, but basically the SARS-CoV-2 is impacting in terms of the interferon and in terms of the chemokines. But so if you read about it in the news, this is what's going on. But I like my graphic better. Get your bats or leave the front door open versus the alarms. Anyway.
Great way to break it down for us, Glenn. Thank you for that. So just wanted to remind everybody, shortly we're going to be turning over the floor to your questions that may be coming up now. And thank you everyone for sending in your questions during the week. Very helpful as Glenn prepares the presentation. So if you have a question, you can send it to me in the bottom in the chat, and I'll get everybody queued up and I'll call on you to ask your questions. So start thinking about those questions. And in the meantime, Glenn, a question has come in about the glycan shield. And can you talk about what that is and if that will impact vaccine development?
Yeah, so this is a very interesting thing. So for a while now, we've been talking about SARS-CoV-2. You know, I don't even know if I have a picture of it recent. So it has the spikes. That's why it's called the coronavirus, because of these spikes that are sticking up. And the spikes are what the antibodies are mostly going to bind to in order to be neutralizing antibodies. The problem is that there are these sugars, so these glycans that bind to the spikes, and they're like a camouflage. And so some viruses use this camouflage on top of their spikes as a way to prevent the antibody from finding them. So the antibody might be set up for the spike, but if they're covered in camouflage, then it does not require a mutation in the virus itself. The virus might not mutate like we're seeing in SARS-CoV-2. There's not very much mutation, but the sugars themselves could be changing. They could be like flexible, and they might make it very hard for antibodies to bind to it. This is one of the primary reasons why we, over the last 30 years, we have not been able to find a vaccine for HIV. It's not because, so HIV is mutating at a greater extent, but when we find vaccines that we think would be useful, the vaccines aren't even useful very, very much against the specific strains of the virus that have not mutated for HIV. And it's largely because of these glycan shields. And what we're finding is, unfortunately, SARS-CoV-2 has glycan shields as well. We're finding out a lot more about the glycan shields, so we're going to be able to address them, but this is something we're going to have to worry about, and it might substantially impact our ability to get a vaccine in the next year or so. We will see. There's still a lot of uncertainty here, but this is something we're going to have to be worried about with the glycan shields. It's these sugars that just form on top. They switch around. When they move, it's almost like there's no wind in the bloodstream, but the dynamics, it's the fluid dynamics. They just flap around in the fluid dynamics and make it very difficult for antibodies to bind on and recognize that it's a spike. So this is something we're following. I'll further updates for you about this in future weeks.
Thank you, Glenn. In previous weeks, you've spoken about the different vaccines that are in development, and you took us through the different phases and what that meant. Have we had any shift in any of the vaccines going from phase 2 to phase 3, or is there anything?
Yeah. So some of the messenger RNA viruses are I think about to enter phase 3 in the United States. There was a vaccine that entered in China, but most people in public health, or I don't know about most, but a bunch of us in public health in the United States we don't know what that means for us. So if China develops a vaccine, will they share it with us? Right now, there's a lot of animosity between China and the United States for a whole different set of arrays. I mean, we have the current executive branch of the US federal government that has been calling the Wuhan virus as if it's something specific to China, that the Chinese government was related in some way. And China obviously doesn't like that, the way that's being portrayed. But even if China does develop a vaccine, are we going to trust the research and the reports, or will we be suspicious that some of the data might have been manipulated? I don't know. So I don't know what that means for us. There are over 100 vaccine trials that are being designed. So we're going to see different types of things being focused on in terms of the spikes and different proteins that are being targeted. So some might be better than others. In terms of a lot of the antibodies that are being identified, we're seeing a wide antibody response among people who have recovered. And so we're probably going to be trying different vaccination strategies to align with those antibodies. So clearly, for a lot of people that have recovered, they've developed antibodies that have bypassed this glycan shields that we just discussed. So like I said, a lot of uncertainty. We don't know. We'll see.
Thank you, Glenn. We appreciate you keeping us updated. And I think in a previous session, you mentioned that even if there was to be a vaccine, that only approximately 30% of the population would even be willing to take that vaccine, at least initially. So has that changed at all, or do you feel that that's kind of pretty consistent?
Yeah, I haven't seen any change in polling on that. But yeah, I think that it changes dramatically. It's 30% wouldn't want to take the vaccine, say in the before winter if it comes out, because a lot of people would be afraid of safety issues. But then long term, it's the opposite. It flips. 70% would take it after maybe a couple of years have gone on. But even still, those numbers are going to be a challenge. Say this does generate herd immunity, but we don't get herd immunity until 70% or more of the people get vaccinated or have protective immune response. Those numbers are going to take a while to get there. But like I keep on bringing this up, I don't think that we need to have a vaccine to end this whole thing. If we get a series of effective treatments that are incrementally effective and then can develop some cocktails when used in combination are very effective. I mean, as an example, instead of having vaccines, we have these monoclonal antibodies that are being evaluated, where it's an injection, where you might get an injection once every couple of weeks, and it just puts the antibodies directly into your body. And if there's a bad response, then you just wouldn't take it anymore, and you wouldn't have to worry about a long-term consequence to that. Whereas a vaccine, if you get it, you might have to worry for a year or two about the long-term consequences at least. So I personally feel a lot safer if the safety and efficacy are demonstrated with the monoclonal antibodies, and when those are released, and they could be released within, if all goes well, they could hit the market within, I don't know, 6 months or so, or less. And so there's a lot of optimism, or at least I have a lot of optimism for that we could have a treatment like that becomes widely available, hopefully widely accessible, that would allow us to open up and not have to worry, to just go back out and live our lives normally without any fear at all. That would make a big difference.
Wow, that sounds promising. We'll look forward to hearing more about that for sure coming up. So in the meantime, Steve Cohen had a great question. Steve, I will unmute you here to ask your question about specifically what's going on in the Northeast. So hold on, and here goes.
All right. So my question is, it seems like the Northeast is doing so much better. How concerned do we have to be about a second wave, and what do you think the timing of that might be and the severity? Can you tell?
Yeah, that's a really good question. So let me go and say here. So I think that we're probably fine in the Northeast for a second wave not happening before the end of summer. And so our uptake curve does not look like it's very worrisome right now. We still have not fully opened up. So for instance, a lot of gyms are still not allowed to open in much of the Northeast, and restaurants, indoor seating is not permitted in many restaurants. And so the question is, once that is allowed to occur, what will the shape be? And the biggest thing I'm looking for here is, let me pause sharing. The biggest thing I'm looking for is our test and trace capability. Right now, our test and trace capability is really great. It needs to be, the target is between 5 and 15, and the more you have, the better. And the reason is you want a surge capacity. So if the number of top positive tests goes up, you want enough extra people that can jump in when you need them, who are trained. So you can't just pull them in at the last minute. They need to be have large teams available so that they can immediately that day go and react to the top positive tests. One worry is that, so New York, as an example, they had a better ratio a few days ago. They still have quite a lot. So the target is between 5 and 15, but they were above 15, let's say a week or two ago, and now they're within 5 to 15. So I mean, I guess I could say there's still nothing to worry about. They're still at the high end of the target range. But the worry is, if the positive test rate starts to go up as we open up a little bit. So, because right now, again, we don't have the gyms open. We're not back to complete normal yet. Once that people are still not working from home, they're still not going back to the offices if nothing happened. Once we start opening up more, that number is what I'm going to be looking at: the positive test rate, and in particular the number of tracers, because that's going to say whether we need to lock down again. If the number of tracers per test falls below 5, then it's really going to be a challenge to keep it from getting out of control. And I don't know if depending on what we might not need to lock down all the way at first. So for instance, we might need to manage it by say right now it's a great balance. So maybe we'll just persist for a longer time with gyms being closed, indoor restaurants being closed, but maybe outdoor seating and other things can stay open for far longer, just so that we can manage that balance a little bit, and maybe we could proceed for a while on that. If it starts getting very out of control, then we need to regress back. But I think that we fine-tuned it enough in the Northeast that we have a really good sense of what a complete lockdown, what would be necessary to prevent a complete lockdown from happening. I think the situation changes in the fall and winter, primarily because of the seasonality characteristic that we've identified in SARS-CoV-2. We thought that it existed before, that it could exist like the flu, and then we've accumulated a lot more evidence over the last month or two that there does seem to be a seasonality component to it. The effective R, the reproduction rate, is going it's greatly reduced over the summer. It's still high enough that's causing problems that we see in the South and the West and whatnot, but it's a lot lower than in the winter months. And so that's the first thing. The second thing is that in the fall and winter, that's our normal cold and flu season. And the problem is right now, SARS-CoV-2 is a coughing. The symptoms that spread it are not just coughing, it's breathing also, where it's just released in breath, but coughing makes it go a little bit further than the breathing alone. The problem is that cold and flu symptoms, so cold, it's typical that people sneeze, and there's nothing about one that protects the other. So you can get both a cold and coronavirus. You can get a flu and coronavirus at the same time. A lot of people will, and what this means is that now coronavirus is suddenly sneezing involvement. And when you sneeze, the aerosols could go way further across a room, and the spread can be way more significant than what we were looking at earlier. And so this is between those two things, I could see that it will be hard to maintain face-to-face transactions at a level that we would hope we would see. And I'm betting that the lockdown is going to be happening even in the Northeast this winter. And within the South, we're talking about before the end of the summer for sure, probably sooner. It's all about like I said, it's all about that the politics. It's about the one poll. Here it is. Well, I showed it to you earlier, so I don't have to show it to you again. But here it is. This poll is going to drive everything in terms of the lockdown. When Republican voters in the Republican states feel that social distancing is worth the cost to a significant enough level, like years back where we were in March, it's going to have to get back at least to 60%, probably higher, in order for the elected officials in those states to say, yes, let's lock down. And so this is it. This is we'll see how fast it rises in the coming weeks.
So that's a great segue, Glenn, to our next question. Sanzi Rock, I will unmute you to ask your question about masks and beyond. So here goes. Okay, you've got the floor.
Hi, guys. Thank you, Glenn, and thank you, Becky. I live in a state where politics, and I don't want this to be political, is going to be really hard for things to change in terms. I live in Florida, where Governor DeSantis is going to approve a lockdown. But I will tell you this: tomorrow morning, I think it's going. I just heard somebody say that tomorrow morning it's going to be mentioned that Palm Beach County beaches will be closed 4th of July weekend. So that's hot off the presses. So maybe there's hope. But my question is, all this mitigation like lockdown, not short of lockdowns, tracking and tracing and all the other mitigations that we've done, it sounds like the only thing that really is left to protect us will be masks and proper use of obviously personal hygiene of washing hands and such. But I don't see how that can possibly be enforced. Already our governor has said sheriffs feel that they don't want to be protecting people. Well, not that, but that they're not going to be enforcing people who are not willing to wear masks. So I'd like to know if that doesn't happen, how will we be protected? It's going to be a free-for-all. You have to lock down yourself, as you said, a lot of older people are doing.
Yeah. Unfortunately, there's not much else that we can do. With masks, there was some controversy for a while about how effective are masks. We know that they're not 100% effective, and we know that they're not amazingly effective. In terms of like no effectiveness versus purely effective, they're very effective, but not as effective as other, like we need to social distance and everything on top. So there was a debate about whether we should even be promoting masks at first, because we didn't want people to feel like they were invincible. All they would have to do is go out in public and wear a mask and everything would be fine, they'd be safe. What we know is that a lot of people aren't wearing masks perfectly. And so if the glasses fog up and it's not completely tight around, they're uncomfortable, then it's not purely effective. And so social distancing and mask wearing together are hugely effective. And I mean, just to be straightforward, masks are effective. So for instance, if you wear your mask properly and you are willing to sneeze into your mask, I know it could be kind of gross for some people, instead of taking down their mask and sneezing in the mask and walking around for hours after after you've sneezed in the mask, it's not something that people might want to do. And the problem is if they don't feel comfortable doing that, then the mask is useless at that point. And so I don't know. There's the one thing to keep in mind, before you follow up, the one thing to keep in mind is that generally outdoors exposure is a lot safer than indoors exposure. Having said that, when you are outdoors, the further away you are is the most important thing you can do. For every 3 feet distance approximately, the first 3 feet is the most important. Within 3 feet, it reduces your risk of exposure, even without a mask, by like 80%. And then each additional 3 feet reduces it by another 50% of that. So that makes a huge difference. The masks on top of that make an even more important impact. But I mean, if you're 20 feet away from someone, then even then the masks aren't even as important. I mean, it's still useful to signal that you care and that they care. But at that distance, when you're outdoors, there's not very much risk. Indoors, totally different story. Social distancing numbers change, the mask effectiveness changes. Indoors, it's the likelihood of exposure goes way up relative to outdoors.
In due respect, the authorities that be, the scientists initially gave misinformation, I think, that masks, I think they wanted to save the N95 masks for the, what are they called? The EMTs and the nurses and the doctors and whatever, but the essential workers. But by doing that, they, I think, put everybody on the alert that maybe they weren't necessary and now they're sticking with it. So
yeah, it's definitely better. I don't want to dissuade anyone from using them. Definitely use the mask.
I understand
They
that.
just don't make us invincible, is all I'm trying to say.
But they have to give clear information all the time.
There's uncertainty is the problem. Even with the masks to this day, there was a big study that was just retracted, or it's debating over whether to retract it because it was incorrectly posted, where it was saying that masks are more effective than we thought that they were. We thought that like, here's 100% effective, here's no effective. And originally we thought, okay, maybe there's somewhere in the between. Then a new big study came out that said, oh no, they're very, very effective, almost purely effective. And now that's being retracted because of the data was incorrectly input or something. And so there still is authentic uncertainty. Definitely for a variety of reasons, everyone should be wearing masks. My point is that it does not make us invincible wearing these masks, and so we just have to take care.
Thank you.
Thank you, Sandy Rock. Great question. Glenn, thank you for all of those great details always. Does anyone else have any questions? You can raise your hand. Oh, it looks like Harry Grossman has a question. I will unmute you, Harry. One moment. And there you are. Okay. All right, Harry, you are unmuted.
Okay, so the question is, there's research that indicates that a variety of patients, some of them are having severe cytokine storms, and others are having very unreactive cytokine storms. So why is there two different reactions to what appears to be the same virus?
That is a really good question. So it's related to the idea of the host, so the person who gets infected versus the virus itself. You're right, it's exactly the same virus. There's a couple different slight mutations that have occurred in different parts of the country. The predominant virus is the one that we saw in New York City that's going around now, but it's essentially the same virus. You're right. So now in terms of the differences in the host, why do some people who are over the age of 75, why are they more likely to be at higher risk versus younger people? What about people with comorbidities or people with higher risk of heart disease or strokes? And the body changes as we get older. So people's immune system changes. The thymus, where some of these T cells and B cells are made, gets smaller over time in people as they get older. And so there's just less of the immune system itself changes. And it's one of the reasons that vaccines, when people get vaccinated at different ages, they might need a higher dose when people get older, because there's just not, their immune system can't respond to it in the same way. And that's the primary reason to your answer. I mean, it's a pretty simple answer. In terms of the specific reasons why, I mean, there's a bunch of things that change in the body as the body gets older, but the immunologically, it's just a consistent story. Just in general, there's a lot of things that change, and that's that SARS-CoV-2 causes the most damage to that. That's just based on some of those changes.
Thank you, Harry. Great question. Or feels kind of weird to call you Harry. Thank you, Dad. This is a family event in some cases. Thank you, Glenn. Okay, so how about we talk a little bit about medical geography? I see you've got your great chart up. And then we always like to end with good news when possible. So maybe you can share a happy dog story. You had some good ones for us previously. So
absolutely. Okay, great. So I'll go through this pretty quickly. In previous weeks, I had talked about medical geography, which I just find so fascinating in terms of helping to understand the underlying distribution of disease and risk factors in a geography, and then showing what that might mean for our future in terms of the distribution of where the disease actually hit. Now what I'd like to do is look at New York City, where we have gone through the first wave in New York City, and see how, look retrospectively, look back to see, well, where were the infections the highest, and did any geographic characteristics or distributions of underlying characteristics on the geographic level, did any of that match up with the infection rate? And so what we're looking at here is the ever infected. So this is a series of antibody tests that are serology tests that the New York City Health Department, in coordination with the New York State, conducted across the boroughs and across the neighborhoods. And so you see that the darkest of them are approximately 30% test positive for SARS-CoV-2 antibodies. So this is ever infected. One thing that, just as an aside, so there were some early indications in the last couple of weeks that we found some early indications that now we were hoping that the persistent protective immunity would last for a long time. Now it looks like in some people, the level of protective immunity might start to diminish even within 2 to 3 months. And so this is a lot quicker in terms of the reduction of the protective immunity than we saw with SARS or MERS. So it's something to be worried about or not worried. I mean, I don't want to cause any worry, but it's just something to be aware about. We don't know a lot about this, but we're still trying to figure it out. But let me just run through some of these examples. So again, on the right here, we're looking at percent positive tests. I think that it was probably pretty accurate in terms of the ever infected. We know that there's false positive rates, false negative rates. There are definite issues with that. And there are these issues that we don't know how long the immune response lasts. All of those are valid points, but at a high level, I think that this is still informative. So you can see the neighborhoods that were really hit hard, and then the ones that really were not hit nearly as hard. So when you look at, okay, where are the people living, in what areas are they over age 65? And interestingly, so some of these areas that are over age 65 by Central Park were not hit very hard, even though they were the ones over age 65. Here you can see a cluster of people over the age of 65, but not a cluster of the disease that really stands out as in contrast to what you see over here. When you look up in this neighborhood, you see got hit really hard with SARS-CoV-2, but did not have a lot of people over the age of 65. Some of these other places where there were a lot of people over the age of 65, you see just a small signal here, but it's really not as dark as some of these other places were. So it's interesting. This doesn't really explain it very well in terms of where the infections were actually occurring. Of course, age 65, that's more of a severe risk factor among people who are infected if they are to be hospitalized or, God forbid, die. But like I said, early on in the infection, there was a dramatic overlap because of the lack of tests. This was not where the tests were. This is ever infected. And at the beginning, like I said, also, people didn't know. There was not really much sheltering in place early in March. And so the risk of getting infected was roughly the same, regardless of age.
Glenn, we have
yeah.
a question from David Brodsky. David, I'll unmute you shortly about the antibodies and the testing for the antibodies. So David, I am unmuting you. And you're
Hey, Glenn. Thanks, Harold. Thanks a lot for this. This is great. So yeah, my question is just kind of a follow-up to this question of antibodies, which is, how do they know what antibodies to look for, and how do they know that they're looking for the right ones or for all of them? And part of my question comes from just that here in New York City, I know a lot of people who had COVID-like symptoms, but then tested negative for antibodies. And I know that there's a lot of reasons why there can be, false negatives, false positives, but specifically, my question is around, so there are many possibilities, but I want to have you explore this possibility of, could there be other antibodies that the body would produce that we're not looking for, or just how did they go about, how do biologists, virologists know what antibodies to look for?
Yeah, let me get more into this in a later week, because I think it's a really good question. But generally, you can look at a few patients and characterize them really, really well. So you look very deeply at all the different antibodies that might be produced. You look in the lab to see how they actually react. You see if they're neutralizing antibodies, which again, that type of antibody is sort of like, it sits on the spike itself, whereas the antibodies can occur throughout the body. What they're looking for generally are for the most common antibodies that have been found. And so that it's representative on a population level. It's not 100% accurate, to your point, but if you're looking at a population level to see, for instance, asking the question, what neighborhoods have been hit the hardest, this is a very accurate representation of that, because you'd expect that the distribution of antibodies would probably be the same regardless of who is infected. So if someone was unlikely to be infected here, they would have the same likelihood over here. So as an indicator for neighborhoods, this tends to be a really good indicator, and that's why we're looking at this. I mean, another way you can say is if there was a lot of active infection. I mean, so one slide that I can show you here. So this was showing in April the number of positive cases. This was from the PCR tests in terms of the positive cases in April. You see that these don't match up 100%. That there was a lot of infection going on, but it wasn't captured in the PCR viral tests. So doing the antibody test is still really useful at a public health level to understand where the spread is occurring, so that we can jump in do increased viral testing, increased tracing in those specific areas that were clearly not tested sufficiently during the outbreak. So does that make sense? It's not perfect. Nothing is perfect, but it's still useful.
Wonderful.
But
Thank you, Glenn.
I
So,
can, let me just have another couple minutes on this, and then we can tell the happy story.
and then
Um,
we have one more question that Jennifer wants to ask when in between this and the happy story.
Okay, great. All right, so here is the population density. We were thinking, okay, well, maybe if people live in more urban areas that are more tightly together, then they're riding on the subways and they're just much easier to get exposed just because of how the proximity that they are. But when you look at that, you see, so for instance, in Manhattan, in the city itself, you see huge amount of population density, but yet you don't see a lot of infection when you look at the serological test. Part of that is we do know there was some flight from New York City during the infection. People didn't want to be in the city, and if they had somewhere else they could go, then they left. But also there tends to be a little bit more wealth in Manhattan itself, and so people were able to not be impacted as a result, that they could order in the food that they needed, and maybe they could work from home or whatnot. But so population density does not have it's interesting. It doesn't have a strong overlap. There's some places, so for instance, when you look up here, it was hit pretty hard, and that's where you also see more density. But over here, you see it was hit pretty hard, but there was not as much population density. So still very interesting. When you look at median household income level, you see it doesn't. So I guess the places where the household income is the least, we want to look for the lightest areas, because that we found is strongly impacted with the SARS coronavirus. And it's not a really clear signal that we're looking at. In some places maybe a little bit, but really not very clear signal. When you look over here at poverty, which is a much better indicator typically, even that. So you see that poverty is the highest rate up a little bit north of the Manhattan. And here you see that it was hit harder, but yet there's a lot of unexplained places that were hit really hard that you just don't reflect. It's just not a clear overlap that we're looking at. When you look at medical insurance, you do see some overlap here in this area and some of these others, but over here, again, unexplained. So it's not really good looking at places. People of color, unfortunately, this does have a lot of overlap with what we're seeing. So for instance, when we see this high area over here that was hit, this is the first map that I've just shown you where you see this similar high overlap of a percentage of people of color that goes through this whole area where we see darkness in terms of the impact of the prevalence of SARS-CoV-2 and then the impact of just where the underlying population is living. You see it a little bit here, you see it up here, you see it over here. So this is right now from the graphs I've shown you, the strongest predictor, which is worrisome for a lot of reasons. I mean, obviously we talk about Black Lives Matter, we talk about all these burdens of healthcare that people of color are dealing with. But now we see in particular here, just on the first wave of New York City alone, this is striking. And the worrisome thing now going forward with the rest of the country, so the West and the South in particular, is I showed you these maps previously. And when you look at where Blacks generally live in our country now, it tends to be in the South, there's a higher prevalence, and in the West. And so in the South in particular, this is very worrisome, and it means that we might be seeing a larger uptake there. And Latinos are more on the West and parts of Texas, and New Mexico and Arizona. And so this is something that we need to be keeping an eye on. So we've had all these other risk factors. We know that these things are risk factors. A lot of it's risk factors for severity of disease, but it didn't really tell us a lot about likelihood of getting infected. But now we know, based on this, that there's a huge predictive probability based on this map in New York City's experience on probability of being infected. So this is something we all need to be aware of, and we need to be anticipating it and helping to protect our citizens who are at greatest risk. All right, I'll open it up to you, Beck. What's your question?
Okay, Glenn. So we'll end with Jennifer. Jennifer, I'll unmute you. Jennifer has a question about guidelines from the American Academy of Pediatrics in contrast perhaps with what the CDC is putting out. So Jennifer, I will unmute you and you for you to ask your question.
Thank you so much, Rebecca. And Glenn, thank you so much for having me. I live in Los Angeles. I work at Cedars-Sinai, and I'm also a board president at a day school in LA. That's how I know Rebecca.
Great.
So thank you so much. This has been so very, very helpful. So the AAP just released their considerations a couple of days ago. And based on the developmental needs of this age group, slightly looser than the CDC in terms of distancing and mask compliancy. Have you guys started to examine the potential outcome of this? I know these are, this is early, and their messaging is slightly different than the older kids that have the ACE and gateway to the virus in their upper respiratory. What are we looking at potentially here? If, let's say, schools can open. Again, I'm in Los Angeles. I think we are a perceived hotspot right now. We are supposed to open August 10th, a little bit earlier to leverage our hot months. I'm concerned about teachers. I'm concerned about mom and dad, Saba and Safta, kids coming home. What do we understand about transmission? Is it still understood or believed that the kid that would come to school as a vector likely would be asymptomatic and got it from an adult, and they wouldn't really transmit it to other kids? What are we looking at schools? And again, I should probably preface this, end with that I think that American Academy of Pediatrics is really looking at our public school system. How do we mobilize the public schools, get them back, get them their, make sure they're up to date on their vaccines, make sure they get the food that they need. There are many other areas that are factored into these recommendations, and it may not be fully aligned with what we're seeing in our day schools, or rather what we can give in terms of some of the prevention we can take in our day schools.
Yeah, I don't have a lot of insight into what they're doing. So there's not a lot of feedback I can say. I do have a couple of things I can add to it, I guess. The first is that we found that this has been pretty consistent. The numbers have changed a little bit, but the risk among people under the age of 20 is extremely, extremely low. So we have found that they can get infected. So kids can get infected. The infection rates tend to be, the R values tend to be a little bit less than for adults, so they don't spread it quite as easily. So in terms of the spread among kids, it's not a huge concern. And I think that's probably why they're being more ambitious in terms of opening it up. From my perspective as an epidemiologist looking at the population as a whole, so I'll leave this slide, but I'll just say they're looking at this, and it's been consistent across countries. It's been consistent across the months that we've been following it. This population is at extraordinary low risk for this virus. It's very, very scary for older people or people with severe disease. But if there's no underlying conditions that would make them at increased risk, then it's really not a worry for the kids themselves at the population level. For me, I keep on going back to this idea that it's chains of infection. So then you have to start maybe thinking about the teachers, the staff, and other people who might be at increased risk. And that is a legitimate concern. I don't know what this means. I don't really have any advice in terms of that. The worry is, I know in terms of the decision back in March of whether to shut down some of these schools over there, or in the Northeast at least, or throughout the country, was about the kids going home and then infecting their elderly parents and infecting the other higher risk people. And I suspect that is still a risk. It's a legitimate fear. I don't know what that means in terms of these recommendations. There's a lot of uncertainty. I worry about epidemiologists conveying false precision into many of our answers, and I don't know. That's all I know. Yeah.
Thank you, Jennifer, for the question. And I know as the next few weeks kind of unfolds, Glenn, we'll be hearing more and more about schools and the advice from the medical community, epidemiological community, et cetera. So to be continued, yes.
On a bright note, you want me to end with the good story? Yeah?
Please.
Okay. So we have found success with dog scans. I shared this with you a few weeks ago, that dogs were being evaluated with their great sense of smell. We've already identified for some other diseases that dogs can actually smell signals of some different kinds of diseases, because diseases cause different changes in our bodies that generate odors, that because they're volatile compounds that dogs can smell, which is so fascinating. Sometimes people can smell them too, but dogs in particular have really sensitive noses. And so in this study, this was done in a few different hospitals. One of them was in France, so I can get into it in a little while. These are two dogs in particular. There were a bunch of dogs that were studied. This one's Gun, this one's Oslo. And so the question was, can they reliably detect COVID-19? And so this was the study. This was the way that it was set up. It's a little bit gross, but they took some samples from people's underarm odor, and then they took the samples and they stuck it in these contraptions, and then they had the dog put their nose in this little cone to smell and see what they could smell. And here are the results. The success rate was huge. They varied between 80 to 100% success versus what you would have expected from randomness alone. Because if you see in this picture, you might have one positive one in one of these, and then all the rest are false, and or like have nothing in them. They're just false. And so simply by doing, or rather have sweat from people who are do not have the virus. So it's still, you'd expect some sort of smell that would distract. And so you'd expect it to be closer to random, and it was demonstrated that dogs are very effective. In fact, there were 4 dogs in particular. I mean, this is not a huge sample. What are we talking about? Less than 10 different, we were talking about 8 different dogs, but it's fascinating that the dogs that they tested were really reliably effective, very accurate. So 4 dogs, 100% of the time were able to detect COVID-19. And the other ones were still very effective. Who knows, maybe they could have been trained to become more effective over time. But what this means is, it means a couple of things. One is that now we know that there are signals that are released on people's body where we might be able to then create our own separate tests, use and identifying what those signals are that are generating the odor, and then maybe have more accurate tests for seeing if someone has a current infection. So if you could, once it's an odor, then maybe it's a much more immediate test. So if kids are coming back to school and other people are, you're going to airports or whatever, you can immediately do the test, and you know, and maybe in a way that's even more accurate than the PCR test or the antibody test. That's the first thing. The second thing is, imagine if you have this at an airport. If you had a series of dogs, I've been at a bunch of airports where they have dogs that are sniffing for bombs or sniffing for other things. So they've been proven to be very effective for detecting that kind of stuff. Imagine how quickly our airports could come back online if you had dogs that could reliably and accurately identify any person who was about to get on the plane to see if they were infected. This could change the air industry and open everything back up again immediately. So this has a lot of commercial potential. I don't know, airline industries, if you're paying attention, or anyone who wants to invest in a new company, call me up. I'm interested in maybe helping to start this new company with dogs. We could revolutionize the airline industry during the pandemic. This, I think, is a real good opportunity. So it's a great story.
Thank you, Sharon, Glenn. We like these good stories, and we also like our dogs. So good stories with our dogs. I mean, it doesn't really get any better than that. Okay, so we will leave with this great news, and we thank you for joining us, both everyone who's with us currently and those who are watching this recording on YouTube and beyond. And Glenn, as I always ask, is it safe to assume we'll be meeting you same time, same place next Sunday at 7 o'clock?
7 o'clock next Sunday. Thanks, everyone.
Look forward to it. Take care.
Take care. Bye-bye.